And good morning, or close to good afternoon. So I'm going to talk today about the glaucoma and optic neuropathies portfolio. It's pretty much a historical perspective with some of the latest work that we've been supporting. So before I begin, I want to acknowledge my colleagues at the NEI. I am responsible for most of the basic science portfolio in glaucoma, but Neeraj Agarwal handles the grants in glaucoma that have to do with the Audacious Goal Initiative and many of the genetics grants. And included in this is the Neighborhood Consortium. If the work involves inflammation, George McKee is the program director, and we have a fair number of glaucoma grants in the SBIR portfolio, for which Jerome Wujek is the program director. And also I want to acknowledge my colleagues in the Collaborative Clinical Research Group, especially Don Everett. They've been instrumental in overseeing many of the clinical trials and epidemiological grants that have revealed a lot about glaucoma. Okay, so it sits in the portfolio at about 13% in 2017. So it's a small program, but it's a growing program. And that 13% will vary from year to year. It just so happens in 2017, it came out to 13%. It sits with the anterior eye diseases group, and so it is, again, a small and growing program. In dollars, it's about $64 million out of a total of $484 million out of the total NEI extramural grant portfolio, and that translates to 160 grants out of 1,256, and this is for fiscal year 2017. Okay, so I have been, I hate to admit this, but I've been the glaucoma program director since '92. And, just to show I don't lack imagination, I did leave the program and I did a number of other things besides it, but in the last few years I've come back to it. So I just want to give you some of my observations, and they're certainly not novel or original. It's a clinical program, so I work very closely with the clinical group on many issues. The observations and findings in the clinic inform the basic research, and the basic research supports the clinical observations. And the basic research also has provided us with a number of drugs and diagnostics. So you can say, well, what's the big deal? This is the NIH mission, is bench to bedside. But I want to show you today that the glaucoma program has been exceptionally successful in carrying out this mission. The other observation is it's considered historically an anterior eye disease, but it is a disease involving the whole eye. And so this is a schematic, and most of you already know this, so just bear with me. In a normal eye, oops, let me get this. Oh, no, wrong way. Is this the pointer? Okay, at the top, you showed me this. I'm sorry, I'm just not. Oh, there it is. Okay, so so in the normal eye, aqueous humor is produced in the ciliary body, and it is secreted and circulates through the anterior segment, where it leaves the eye in a tissue, the filtration type tissues, the trabecular meshwork and Schlem's canal. In a normal eye, there's a balance between secretion and the outflow of aqueous humor. Now, there are two functions that aqueous humor has. The first function is that it provides a circulatory system for the front of the eye, because the front of the eye is avascular, as most of you know, and it is also it forms a circulatory system providing nutrients and taking out waste products from the cells in the front of the eye. It also provides the pressure, the normal pressure for the eye. The balance between secretion and outflow creates a pressure that maintains the eyeball. So that's a normal eye, but in a glaucomatous eye, that aqueous humor is secreted as normally as it is normally, but it doesn't flow out of the anterior chamber through Schlemm's canal and the specular meshwork. It flows through. There is a blockage. No one knows what that blockage is. In most forms of glaucoma, there's no obvious insult, but the insult occurs at that level, at the level of outflow, in that filtration tissue system. So when when outflow doesn't occur normally, you get a buildup of pressure, and the pressure is particularly damaging to the optic nerve head. That area seems to be particularly sensitive to pressure. And the optic nerve head is where the retinal fiber layer axons flow out of the nerve, out of the eye on the way to the brain. So there's damage at that point. The retinal nerve fiber layers begin to drop off, and the retinal ganglion cells start to die in a slow, chronic method. Okay, so the portfolio distribution this is sort of my impressionistic interpretation of the portfolio. There's the front of the eye, as I said, and all the research that goes on in the front of the eye, and then there's the back of the eye, which is really what the glaucoma program has become increasingly interested in. So the front of the eye is about 36% of our extramural grants in glaucoma deals with the front of the eye problems, where that insult is. It used to deal quite heavily with aqueous humor production, and as you'll see, there are a lot of pharmacological agents that were developed from those studies. But right now, most of the aqueous humor grants have to do with outflow, because the search is for what that area of insult is and to correct it. And there's a lot of pharmacology in the program. We have a fair investment in genetics. We started out with Mendelian genetics, the easy diseases, so to speak, but that really isn't the important type of findings that we want. We want the genetics of the complex disease, so we've been investing in things like genome-wide association studies. We have a lot of diagnostics being developed. That's about 10% of the portfolio. Optical coherence tomography, trying to get better visual fields, psychophysics, understanding progression. We have a number of studies in diagnostics. And, of course, the back of the eye, which I am not going to touch because we have someone who actually knows something about this. Don Zach's going to come and follow my talk, so I'm going to leave that all to him. But that is a growing portion of our portfolio, and there's a lot of studies on retinal ganglion cell death and optic neuropathies and regeneration. So you'll be hearing from Dawn on that. Okay, so there are many types of glaucoma. It's not a singular disease. Though 95% of our portfolio is on the adult form of primary open-angle glaucoma. That's about 95% of the portfolio. And I'm going to predominantly talk about that form of the disease. And so I'm just going to use glaucoma and primary open-angle glaucoma interchangeably, and just assume that's what I'm talking about, unless I say otherwise. There's also a fair amount of what's called normal tension glaucoma, where there's no obvious elevation in pressure, but yet you do have damage, and some smaller forms of glaucoma in terms of the prevalence, pigmentary dispersion, exfoliative glaucoma, and one of the small but important forms of glaucoma is juvenile open-angle glaucoma, because that was the beginning of genetics for us. Also, congenital glaucoma, where babies are born with very high pressure. So there are multiple forms. Mostly we're interested in this form because it's so prevalent. But all of them have in common the optic neuropathy that underlies glaucoma. That is, there's loss of ganglion cells, there's dropout of within the retinal nerve fiber layer, and as a result, you get cupping of the optic disc at the optic nerve head. So the risk factors for glaucoma, I'm going to show you some data on this, but the major risk factors are age and race. Family history and elevated intraocular pressure are important. And, you know, interestingly, thin corneas turn out to be a major risk factor. Worldwide, the prevalence of glaucoma is about 2.2% of the population overall, but in African populations, it's double. It's cause of blindness worldwide. In 2 million people, it causes blindness. The U.S. statistics pretty much mirror those of the rest of the world. About 2% overall in the U.S. population have glaucoma. But in the African American population, you can see that it's much higher. The prevalence is 4%. Again, double what it is overall. About 120,000 people are blind as a result of glaucoma, and it accounts for about 6% of all blindness in Caucasians. But again, I really want to emphasize that this is a serious disease, even though we have treatments. In African Americans, it's at 19%. That's very, very significant. And this also is just more of the prevalence data. As I said, age is a major risk factor. So at younger ages, middle age, it's about 0.9%. The prevalence is about 0.9%. African Americans at that age, the younger ages, it's 2.25%. Very significant. Once you hit your senior years, it's 2% overall. The prevalence is 2% overall. African Americans, 6%. And if you end up being over 80, the prevalence is about 7% overall, almost 10% in African Americans. So I'm just sort of trying to emphasize that we have a significant issue with primary open-angle glaucoma. Okay, so when I joined, there was a lot of discussion about the role of intraocular pressure, IOP. Is it really important in the etiology of glaucoma? And this was actually an ongoing debate, even though people were treated to lower pressure and through meds and surgical means. It was by no means certain that this was doing any good. And why was this conundrum, cited? Because it turns out that a fairly significant number of people with primary open-angle glaucoma actually had normal tension, normal IOPs. About 30 to 40% had around the same as the non-disease subjects. There's also the converse. Ocular hypertension was found to be fairly common, and that's elevated IOP, but no optic neuropathy. So this created sort of a controversy. Does treating IOP, lowering pressure, really have any effect? So I want to point out two studies that were supported by NEI, very significant studies, really changed the way we think about glaucoma. So the first study I want to cite is the early manifest glaucoma trial, and this was very controversial, and it was considered unethical and could not be done in the United States. So a group in Sweden took control of this study, and they did a randomized clinical trial that compared the effect of immediately lowering intraocular pressure with no treatment or delayed treatment. So that, as I said, clinicians, even though they had no proof that lowering would be effective, they still were adamantly opposed to this trial. And it was important because at the end, based on visual fields and optic nerve progression, results for all patient categories showed considerable beneficial effects of treating to lower IOP. There was a significant delay in progression, and this delay was regardless of age or whether you were in the high or normal tension category. So it was very important. It sort of laid to rest that controversy about IOP. And the second trial was the role of intraocular pressure in ocular hypertension subjects. So this was a randomized trial to determine whether topical hypertensive medication delays or prevents the onset of primary open-angle glaucoma. And these subjects would show actually no optic neuropathy, had very normal cups, etc. But should we treat them? So this was a big question. Well, again, a randomized clinical trial that compared the effect of treatment versus no treatment in patients with elevated intraocular pressure, but no other characteristics of glaucoma. And so again, based on visual field and optic nerve measurements, the treatment with IOP lowering medication was effective in delaying or preventing the onset of primary open-angle glaucoma in these individuals. Okay, so that pretty much solidified the idea that treating for pressure is a good thing. We can really save sight by treating individuals with IOP lowering medications. So in terms of medications, I want to show you that how successful the NEI has been in developing just about all the medications we have on the market today. We have a number of drugs that lower IOP that are used extensively and has saved sight. The first generation, these are just a few examples, but they're the major examples. The first generation were beta-adrenergic blockers. This reduced aqueous humor secretion. So if you have less secretion, you didn't put a burden on outflow. We've had a number of NEI-supported investigators whose basic research went into the foundation of developing these drugs, and the best known is timolol. So I just want to acknowledge that we had a number of investigators working on that: Tom Mittag, John Polanski, Alvarado, Marty Wax. They were from different institutions, and it was our the work that we supported that went into developing this drug that Merck took over. The other drug that was developed to reduce aqueous humor production is Trusop, which is a carbonic anhydrase inhibitor. And this was developed by Tom Marin at the University of Florida. And when I first started here, and way back when, one of the first things that happened was that Tom Marin called me and he said, you know, I understand you're the new glaucoma program director and I'm retiring, but Merck wants this drug, and I've almost got it to the point where I can turn it over to them. My grant is up. Can you provide a supplement to continue for another year? And so we did. We do support. We are very committed to supporting drug development that will save sight. But so these two drugs are both aqueous humor secretion inhibitors. And as I told you, the aqueous humor is very important in terms of giving a circulatory system to the front of the eye tissues. Now, the question became, what happens to those tissues now that they don't have a source or a robust source of nutrients and a way of secreting waste products? So there was concern about using these kinds of drugs, and the aim was to get drugs that increased outflow. And the first of this was the prostaglandin analogs, which increased outflow not through the conventional system of trabecular meshwork and Schlemm's canal, but through a different system, uveoscleral outflow. And this was developed by the late Carl Cameron and Laszlo Bito at Columbia. So what's interesting about this to me is that there was a number of years ago a real revolt by by public interest groups that NIH was providing a lot of the work to develop drugs and turning them over to drug companies, and drug companies were gouging patients with these blockbuster drugs. So about that time, the New York Times did a full-page expose or investigative report. And what drug did they pick? The latanoprost. So that made news, and it died down, but it was sort of interesting that of all the drugs, that was the one that was picked as a prime example of how NIH, through taxpayer money, funds drugs that go into the drug company and profits. But they actually, Cameron and Bito actually took it very far. They did some early, very small trials to show its effectiveness. And this is, I think, the major drug being used now. In the last year, we have another drug that came on the market, the Rho kinase inhibitor, Rhopressa. And this increases conventional outflow. It's not quite sure how it works, but it does work in 3 clinical trials. It was shown to be effective, and it was developed at Duke, or the foundation part was at Duke by the late Dave Epstein and Vicente Rao. So we have been very successful at this in this arena. So now I want to turn my attention to genetics, because we've had some really good findings, as was already mentioned. The early studies that we invested in were basically Mendelian type genetics, because they were easier, so to speak. So the first gene that was identified to have to be associated with glaucoma is the gene that encodes myocilin, and that was identified by Stone's group, and as well as Polanski at the late John Polanski at UCSF. And that gene is responsible for autosomal dominant juvenile glaucoma. So it does pay to pay attention to some of these rare forms of glaucoma. It also was found to be responsible for about 2 to 4% of adult glaucoma. Safarazzi and colleagues found a second gene for cytochrome B, the CYP1B gene. It encodes, it's responsible for a percentage of autosomal recessive congenital glaucoma. And the same group found optineuron, which is found in an autosomal dominant form of the disease, and it's responsible for about 2 to 3% of normal tension glaucoma. So these were the early studies. But I want to move on to what we're doing now, because it's gotten very exciting. We've invested a lot of time and money in genetics of glaucoma. And just this last month, a really blockbuster paper came out, and Nature Genetics from the Neighborhood Consortium, with that group, along with other investigators, did a meta-analysis using GWAS data from 139,555 participants that were derived from 3 European cohorts. 112 loci were found with elevated IOP and our primary open-angle glaucoma. And so now the idea is to really sift through all these genes. And so far we found, and I know Lou can probably tell you more about this, so far there are genes associated with lipid metabolism, mitochondrial function, or I should say regions with genes known to have, to be associated with lipid metabolism, mitochondrial function, and interestingly, development, where, that I found that pretty interesting. So, because it is that outflow system which is blocking. So it would be nice to know if there's some structural problems with that system that we don't see. Of course, the real challenge now is to find function associated with these regions. And as was said, about 133 variants were found that predict with 75% accuracy the risk for developing glaucoma. Now, that's in Caucasian populations, but I spent a lot of time sort of talking about how severe the problem is in African and African American populations. So what are we doing there? We have 2 ongoing studies at this point. One from the University of Pennsylvania, headed by Joan O'Brien, looking at primary open-angle glaucoma in African Americans. They're doing GWAS, exome-wide association studies, and admixture analysis on a cohort of 9,000 subjects, which includes cases and controls. And they're now at the point where results are coming in. Just to give you some highlights there, the multivariable risk model showed, which I thought was really interesting, that male gender is associated with risk. That's never been shown before, I don't think. Is that right? I don't think. Older age, as we would expect, and African ancestry is associated with risk. And there's some crossover with the findings in the Caucasian population, some overlapping SNPs that may have to do with the disease in African Americans. Question is it a different disease? It's just known to be more severe. A second study that we are not funding, but comes from the H3 Africa group out of Genome, and we're co-funding this. And this is the head of this study is Ashe at the University of Nigeria, and she's working with some Duke investigators doing genotyping 120,000 glaucoma cases and controls. And that's pretty early in the study. I just wanted to mention it to show that, you know, we really do want to put our money into finding what's going on in that cohort or that population. Okay, so lastly, I want to just highlight diagnostics, because this is another really successful bench-to-bedside area within the glaucoma portfolio. So, you know, there's always this debate between, is it better to have functional tests or structural tests, or what do we get out of each? And so the gold standard has been functional, the visual fields. But the problem with visual fields is a lot of variability. There's a lot of test-retest variability. And it's subjective. It's a subjective test. It depends on the patient to let you know that what the outcome. So there's been a lot of, over the years, a lot of emphasis on developing structural tests, diagnostics. So because the feeling is there would be less subjectivity, it would be more objective. And I think of all the places we put money, of course, the most successful has been optical coherence tomography. That was developed, again, through a NEI grant by an engineer at MIT, Jim Fujimoto, along with his postdoc, who now is carrying it forward as well. Jim is also working on it still, David Wong. And that was developed in 1991. It's always compared to ultrasound. It images internal tissues, and it's been used to image retinal nerve fiber layer thickness. It's, as far as I know, it's really been, it's another bench-to-bedside success. So a lot of ophthalmologists have it in their office and they use it. It's, at this point, it's pretty much, it's a lot of work has been done, and the whole goal now is, it's slow. So the goal is to increase speed and resolution to get really to a much deeper level in the inner retina. It's to increase applications, to look at blood flows with Doppler OCT, and it's gotten too sophisticated for me. So I just, you know, it really is a lot of engineering that goes into this work, and so I think it's been very successful, and we continue to fund it, and we're getting good results. So just to close with some thoughts on future directions, we've invested pretty heavily in genetic analysis, but you know, that's just description. We need the biology. We need the phenotype that's associated with the different genes. And we need to know which of these genes are really going to turn out to be risk factors. And the other big, I think, the other big area that really needs a lot more emphasis is the disease in African Americans. We need to know more about the genetics and the risk factors and the pathophysiology, considering how severe the disease is. And for diagnostics, we need better endpoints and a measure of progression so that we can go on with some clinical trials, especially now that we're moving into regeneration. And with that, I'm going to introduce the next speaker, but first I'll pause to see if there are any questions about the portfolio.